All right. For posterity's sake, I have my pin, 40 years. All right.
40 years what?
40 years AMTA, 46 years doing massage. Yay! So, soleus is underneath here. They come together somewhat into a common tendon, which we call the Achilles tendon. But there's a split under there. And a lot of times when people think they've got Achilles issues, it's down here. So get your own little foot out and feel the Achilles, pinch it, and then push down into those bones. It's in there that a lot of that pain is at. So that's another spot that you may not think of or may not have learned about or whatever. So that's something that we'll want to focus on. Whoops. Okay, here's that tootie. We've talked about the feet. The big thing I'll leave you with on this is move it in as many different directions as you can and don't skimp on it. So here's a little bit more visual. The rest of these are a little bit more visuals, just to kind of lay in the territory here. So here's that SI joint, and then how it comes into the pelvis. This is you're looking in at the medial side here, and the pelvic floor in through here. These are the adductors. That's that penzance serinus tendon Luke was talking about. Here's an anterior view of this. A lot of times people, they'll talk a lot about psoas and working with the psoas. It may or may not be an issue. It's safer to get it at the lower attachment down through here than it is to go through the abdominal wall. But you can get it both ways. This is an interesting view. It shows you how these compartments are wrapped around the bone. You're looking from the feet up. This is an example of that stability structure with an agonist-antagonist relationship. So these muscles, if they're located on the lateral side, they're going to adduct. If they're located on the medial side, they're going to, no, I had it backwards again.
No, you had it AD lateral, AD medial.
Okay. Did you get that?
Yes.
These will co-contract, both of them contract together for balance. So they function as an agonist-antagonist relationship. So there has to be, when one is contracting, the other one has to let go a little bit. That happens in any movement, flexion, extension, internal, external rotation. You always want to think both sides of the, you want to think both sides of the movement. So if somebody can't do flexion, chances are it's their extensors that are problematic. I screwed up with the, there we go. So here's a cadaver view, and none of these are separated like this. They're all saran wrapped, plastic wrapped together, and they all look like one great big blob in there. But the compartments will have a level of separation in them. We're looking anterior here. There's the adductors. This is another picture of the compartments around the bone. So I can get, if a person is prone and supine, I can get the anterior and posterior compartment, but I can't get the lateral and medial very well. That's where the sideline comes in. This is a really good visual, again, of what we're trying to manipulate. Cross the grain, sliding the tissues in multiple directions, incorporating some movement along with it, and a lot of restriction is happening at the superficial fascial area. And if we don't attend to that, we think it's something going on with the musculature, but the first place something is going to bind is going to be in the superficial fascia and then into the deep fascia. So that is more likely to be something we want to consider. And truly the easiest way to do this is with decompression or some suction. This is some movement here at the knee, showing you the structures that we've talked about. This is the patella, and then this shows you how the gastrocnemius comes up over it. This is the soleus down here. This shows the calf. This is the tibia. There's the foot. There's a pseudo joint line right through here and another one right through here where the tarsals and metatarsals connect. And then the ankle is like the SI joint. There's not a lot of musculature in through there. It's all about how the bones fit together. There's the bottom of the foot. So, I always throw this in, we're talking about the feet. I've never found an eyeball on the bottoms of the feet. All right, so I'm not discounting the idea of reflex action and that sort of thing with your traditional idea of reflexology. I am telling you that there isn't any evidence about these locations. There is a lot of evidence that shows that massaging the feet is a great way to initiate a parasympathetic response, a rest and restore, which is inadvertently going to affect these organ structures. So that's why I threw that in there. Here's some injury stuff with the knee. So a sprain is a tear or a damage in a ligament, and a strain is a tear or damage in, it's usually the connective tissues of the muscle. Occasionally you'll get an actual muscle fiber change. The knee is very vulnerable to damage from the side. So if the effort or if the force comes in here, is that showing up with my arrow? If the force comes in this way, this side is compressed, but this side is stretched or pulled apart, and that's where you'll get the fraying or tearing of the tissues. This other side, though, can end up with a persistent bruise type thing that will linger quite a little while. So remember both sides. This shows your degrees. So this is a little, grade 1, grade 2, a surface tear and a deeper tear, and then a grade 3. Interestingly, the thing that will hurt the most is a grade 1 or a grade 2. And they'll swell, and the more serious ones tend not to have as much pain, but there will be more hesitancy to move. So you can kind of tell here on a grade 1, if for a knee sprain, but this works for ankles and the others too. If they can walk on it, they can weight bear on it, but it's painful, especially, and if they can kind of touch and it's painful, it's probably grade 1. If they don't want to weight bear, they will, but they'll flat foot it. They won't want it to, you've seen this. It's getting to be a grade 2. These right here will probably heal on them themselves if they're allowed to. They need a degree of immobility. So what will happen is people will start walking without bending their knee. Now I've got knee damage on this side. I don't have any ligaments in there much, a little bit on the lateral side. If you watch me move around, you will notice I flat-footed a lot, and I've got a little bit of flexion back here. That's all resourceful compensation. If that gets loosened up, then the knee is very unstable. So, but this is also the kind of gait you would get if somebody's protecting a knee injury. You'll see that they won't want to do that kind of thing. Here, they won't want to weight bear on it. It'll feel like it's going to go right up from underneath them. So that is grade 3. You can tell that. Assessment is here usually. So if they can weight bear on it, it hurts, but they can weight bear on it. It'll probably heal on its own. I'm not going to have a freak out and say you need to go have something managed. I'll explain to them the healing process. As it starts to get worse and they're more scared of it, more hesitant of it, then they need to go get the x-ray and that sort of thing. So, now, once a ligament has been compromised, it doesn't go back. These will heal, but the ends will try to grow together, and so it ends up longer. And it takes a long time. This is a strain, 1, 2, 3. This will be more bloody. And the person is going to feel it when they move it. So on a knee sprain, if I have them move their ankle, they're not probably going to feel it too much. But if it's a strain in the muscle of the calf, they're not going to want to do that. That's going to hurt, and it's going to be very tender to the touch. So the other thing we have to think about is what do we do between acute, chronic, the stages of healing and through here. And what happens? What fills this up? So what fills it up is connective tissue. And so if somebody has had a history of this, you might find a stiffer part when you're palpating and through there. And the bigger the tear, the bigger the stiffness is, and it gets fibrotic. And that doesn't have as much movement in it.
Similar dynamic, stay with this. Partial Achilles strains. Because you don't necessarily need to have most people don't have a full Achilles rupture, and they'll maybe have a small one. And wherever that happens, usually it's closer down here to the attachment, or midish way, that too fills in, and then there's this thicker wad,
And they have to heal stiff. If somebody has torn their Achilles and they go in and try to knit that thing back together, the Achilles is one of the ones that needs to be immobilized in a way that it heals stiff. And then you try to institute more, that's not the word I want, but it's close enough. You try to, after it's healed. You leave it alone. They repaired it, you leave it alone. After it's healed, you might wanna try to get some more mobility in there.
And where that needs to occur is, some on the tendon, but mostly you want to just get the muscle fibers back, because they'll all be guarding up in response to this. What this usually needs is to be pushed back and forth, side to side, so that it's unstuck from any structures deep to it.
So this slide is just, expanding on or giving you some idea of what we had been talking about. Here's the gait, and how the muscles coordinate so that we switch from one leg to the other. And then I'm going to quickly flip through these. We'll come back to these. This is going to be something that we're going to assess and do an intervention with. This is the gait. And then we'll do some assessment on the SI joint here. And then we'll come back and look at some firing pattern things that are related. A little bit more on the concept of fluid movement or lymphatics in through there. And then some ideas on some positioning. So this is a stop so that you can pee. Because if your pelvic floor is tight, your calves are tight. No.